Hello everyone and welcome back to our in-depth exploration of pouchitis. I am Dr. Strange and this is part 3 of our series. Today we are diving into some fascinating aspects that go beyond the basics. So let's get started. So mainly we will cover pre-pouch ileitis, irritable pouch syndrome, primary prophylaxis and natural history and prognosis of pouchitis, mistakes in pouchitis and the conclusion. I hope you have already watched the first 2 episodes and all other videos that we have uploaded on our app and on our YouTube channel in the IVD series for a better learning of this concept. So friend, the pre-pouch ileitis, the term you have to understand that it is the inflammation of the ileal limb just before the pouch. So we use the terminal part of the ileum for creation of the J pouch. That is the most common pouch we used as we said in the previous 2 parts. So there is inflammation. So the incidence is around 5.7% in one of the series of out of 742 patients. The clinical implication of this entity is unknown, and you have to understand the finding of pre-pouch ileitis. As we understand, the Crohn's disease involve the small bowel does not imply or that there is an increased risk of pouch failure because of Crohn's disease, and it can be dealt as on the line of pouchitis with combination of the antibiotics that help to reduce the inflammation and inducing remission. Another entity that you will come across in these patient will be irritable pouch syndrome, and so this is a functional disorder as we talk about the visceral hypersensitivity or irritable bowel syndrome, and so there are symptoms in the absence of any objective inflammation or structural abnormalities. So it is a primary disorder, unknown etiology, and there are no actual finding in the pouchoscopy. So in a study of 46 patients with clinical symptom pouchitis, 25% of the patients had no objective evidence on endoscopy or histology, and they did not respond to empiric treatment with antibiotics. And they were followed and determined to have either irritable pouch syndrome or colitis. So you have to understand that irritable pouch syndrome and the colitis that we will discuss more in the subsequent part is another differential diagnosis. The IgG4, Pianka, pouchoscopy, if they are all negative, then we have to consider the diagnosis of IPS or small intestinal bacterial overgrowth. So these are all differential diagnoses of pouchitis that will be colitis, irritable pouch syndrome, pouch ischemia and stenosis, impaired pouch emptying, infectious diarrhea such as cytomegalovirus or Clostridium difficile. There can be bile salt malabsorption because of the as the colon and rectum is gone, Crohn's disease of the pouch, pelvic floor dysfunction, pouch stricture and adhesions. So these are all the causes in the list as a differential diagnosis for a patient of pouchitis, and you have to rule everyone by different investigations and imagings. So the term primary prophylaxis means that we are before basically developing the pouchitis, we are starting the treatment. So like in all these patients, there will be a divergent ileostomy most of the time, and that is the practice we follow. So we can start this patient with probiotics, and there are many studies available. One of the RCT, they use BCL3 or placebo for 12 months after ileostomy closure. So incidence of acute pouchitis was only 10% in BSL group versus 40% in placebo group, which was significant difference. So there was improved quality of life also, and there are another study with different probiotics also, and the cumulative risk is reduced with the primary prophylaxis. But the flip side of this finding is that we have to maintain this prophylaxis for a long time, because the moment we stop these probiotics, the concentration of these healthy bacteria goes down drastically, come to the baseline, and the incidence of developing pouchitis is again similar to the placebo group. So this is another important entity, Crohn's disease, that will force the surgeon to to do a diversion or to that can lead to the excision of the pouch. And usually these cases will be of indeterminate colitis that we have discussed in the ulcerative colitis series. So different type of ulcerative colitis like indeterminate colitis, it can lead to the later on may manifest as a Crohn's disease also. So must watch that series also in this IBD part. And so the median time of diagnosis is around 19 months, and complication occurred in 93% of patients in which we have a post-operative diagnosis of Crohn's disease, and 29% of patients required pouch excision or diversion at a median of 66 months. So this is one of the most common source of morbidity that can lead to the pouch failure. And friends, do remember that Crohn's disease of the pouch, it's a overdiagnosed or liberal diagnosis. I mean, it is the common mentality of the treating physician and surgeon to label any pouchitis or pouch failure which is because of the Crohn's disease. And so if the patient is symptomatic immediately after surgery, then the cause can be leak, stricture, after within 6 months of IPA. So these are likely to technical details, and if we label them as Crohn's disease, then it will not be a appropriate diagnosis. If we are sure, if histologically we have confirmed the diagnosis, then the biologicals are very good treatment strategy, and 70% of patients will show improvement within 8 months, and that can lead to the pouch salvage, and excision can be avoided. So in a study where they have followed 100 patients of consecutive IPA after ulcerative colitis. So there were 32% patients had pouchitis, 5 were chronic refractory pouchitis, and 39% had acute pouchitis episode which responded to antibiotic, and 61% have at least one recurrence. 5 to 19% patients will develop a refractory or rapidly relapsing form of disease. So the normal cycle will be antibiotic responsive, antibiotic dependent, and antibiotic refractory. The incidence increases over time, that is 25% at 1 year to 40% at 5 years. And if we are dealing with a patient of primary sclerosing cholangitis, then the chances of this severe form of pouchitis are around 79% after 10 years in a patient of IPA. So, any treating surgeon physician should be well aware that the pouch is created basically for two pathologies. Like one will be familial adenomatous polyposis or for a ulcerative colitis. So, the incidence of pouchitis after IPA in case of familial adenomatous polyposis is negligible. So, there is definitely a role of pro-inflammatory genes which are basically leading to enhanced inflammation. So these patients, if develop pouchitis, which are antibiotic refractory, visualizing or stricturing pouchitis, so infliximab has a definitive role, and all of you should remember in one of the study of 192 patients of pouchitis, 140 patients received infliximab and 52 adalimumab. Overall, infliximab had 80% short-term and around 50% long-term response. So this is a very good salvage therapy. Otherwise, these patients may end up with the pouch excision leading to the permanent stoma. So the role of biological, the infliximab has to be kept in the basket and has to be discussed with the patient. So fecal microbiota transplant, another aspect of management. There are many studies available, and as far as the FMT is concerned, it is a safe procedure. However, we don't have any conclusive evidence that it has any long-term efficacy. So data are limited by study heterogeneity also. So conclude friend, pouchitis is most common long-term complication of IPA. The pathomechanism of pouchitis are dysbiosis, dysregulated because of inflammation. Most can be treated with antibiotics. Small proportion will progress to refractory forms. Antibiotic dependent and antibiotic refractory pouchitis, they are challenging. There is a role of biologicals, and always evaluate these patients for secondary causes before diagnosing with the refractory pouchitis. Crohn's disease of the pouch at risk of pouch failure, and that may be rescued with biologicals. So friend, we have very interesting series coming up next. There will be management of thick wall gallbladder. Friends, as the cholecystectomy is one of the most common surgery performed in surgery. Once in a while, you will encounter this patient with thick wall gallbladder. So it's a diagnostic dilemma, and we are not sure how to manage. So we will be covering in detail. So stay tuned. And if you're watching this episode on our YouTube channel, then don't forget to hit the like, subscribe, and the bell icon. For a better learning experience, it is desired and recommended to download the app or join the channel membership for exclusive SD contents. And the link for everything is available in description and pinned comments. So thanks again for watching, friends. Pouchitis, it may be a bit boring topic for you guys, but as an aspiring GI surgeon or a general surgery trainee, you have to understand these entities. So thanks for watching again. Stay curious, keep learning, and I'll see you in the next one. Happy learning.